Today we're going to show you a patient we're going to correct minimally invasively. If you look at her foot, you see how these two toes are drifting medial, and it's giving her an ulcer on this side here. If you come over and film this side here too for a second, you see the ulcer she's getting on the tip of the toe. Now it's important to be able to clear these up. She would not be a very good candidate to go to the hospital with and put to sleep, so we're doing this in the office setting. If you look at her other foot over here, come look over here, you can see that she's already it was the second toe, wasn't it? She had trouble with the second toe, got bone infection, and we had to actually do an amputation on her toe. That's been some years ago now. So this toe, we don't want to have bone infection. We're already getting some infection here. So we want to correct this minimally invasive. So minimally invasive surgery can be used to correct ulcers like this, and also to prevent ulcers from coming around. And this patient, she's not a good candidate for being put to sleep or anything like that. Matter of fact, we wouldn't be able to do that for her right now. So we've done this in the office. We're going to correct this toe and this toe with a minimally invasive technique. This little procedure we want to do to get rid of an ulcer here. You can see how the transverse deformity is pretty bad. Now you can take your C-arm and look at exactly where you're at. Well, you can palpate too, so that's what I mostly do. We want to reduce our exposure as much as possible to both the patient and also to me as the surgeon. What we're going to do, we're going to correct the transverse plane deformity she's got, causing an ulcer here. We're going to actually make a small incision on the side here, and we're going to do a wedge outside, which will pull that toe this way. Off of this toe, we'll do the same thing with the second toe. Now what I normally do is kind of go a little bit medial. You don't have to go all the way, you just kind of small little incision like that. And then take your grafts and just punch right through that. It's kind of easy to do. And we're going to take some of the periosteum off the bone there. Now this can be done under the C-arm. You don't have to hold the C-arm in there all the time. I know where I'm at by looking at my toe. But now, that's all the incision we have to make. And we take our burr, lay it right beside the bone. We're going to cut a wedge so the toe goes this way. So we start cutting that wedge. And if you notice, I'm not running this wide open. This is pretty slow. So go slow with it. You don't go quick in terms of like the speed of the burr. It has to be very, very slow. And once my osteotomy is almost complete, I start pushing the toe to where I want it to be, which is right here. And I keep reducing bone until that toe stays there. So I'm putting a wedge in that bone so that bone stays over. You see where the toe is now? So what I did was I cut it and I took more wedge here than on that side. That's going to stay over like that. Probably take a little more wedge to make sure it holds steady. Wedge it on over. Real slow with the burr. And you see it comes out of the paste if you look down at the bottom. We're not hitting our soft tissue. We're staying right with the burr in the bone. So you see the result now, the bone is totally over. So now we got to take this one down and over. So we're going to push down and over while we run our burr through that. This is the same thing. I can palpate where my bone is. There's my base. There's the head. I go about right here, and I'd be near the base. Make a tiny incision through the skin. And take our small rasp. Take off our soft tissue and periosteum. That's going to be the course we'll go with the burr. We'll do the same thing with this. Get our burr hugged up to the bone. And we'll cut a wedge and push your toe down. So once again, you're not wide open this burr, you can barely hear it. So do you hear it? You might not even hear it all on the tape there, but it's real slow, so mostly it's a technique, it's not speed. So I'm pushing the toe over and down. At the same time I'm making my wedge. Through it now, I'm going to make it wedge down. So what I've done is use my non-dominant hand to manipulate the osteotomy while I'm performing it. So now when she stands, that's going to be significantly off her big toe. We'll tape these over laterally with tape directly to the skin, and these bones will heal over like this. Okay, so basically our surgery, I'm going to show you the taping as well. Feeling okay? No pain?
No, I feel so alright.
Alright.
Do you want a suture?
I'm thinking about not suturing, just so anything that needs to come out can come out. Took a lot of bone. I want to see for a second, okay? So all I'm going to do is take this a sterile band-aid and start with that, and then I'll go over with the tape. Okay, so now we've got the surgery done. Our wounds are staying clean, so we're just going to go over the top with a clean tape. It's not sterile, but it's clean. We've got a barrier with a sterile band-aid. This will help us pull the toes in place. So we go down here, pull the toe that way. And this is almost like casting the bones here. It acts as a stabilizer and immobilizes these areas. And do both toes individually like that. Wrap them both over. And usually do that all the way around to kind of give you a good place to get the tape to. And kind of put these bones where you want them to be. And they'll heal there. You gotta watch out when you start doing this so you don't rub these wrong. So what you have to do with this, make sure you put your little spacer between these. Just so you're not kind of pushing over too far and causing another sore. Keep a little space between the toes. Keep in mind the first layer is a band-aid, which is sterile. So nothing's touching the wound that's not sterile. Okay, she can walk on this with a surgical shoe. And we'll keep this in place for about 2 weeks, and then we'll go 2 more weeks, and we'll pull this out and she can tape it at home like we show her how to do with Band-Aids. Alright, so that's it. We did it all. You doing alright? Good. Got your straight toes now.
Good.
Okay, so that's an example of what you can do with minimally invasive surgery. We were able to fix her foot with under local anesthetic. I went to the hospital. She can't be put to sleep. She probably would have lost that toe as well if we didn't fix it, so it didn't be corrected here in the office. Under local anesthetic. Patient doesn't have a risk of anesthesia. A lot of things are better for this. Much less cost. If the patient would have had this would have turned into like a bone infection, would have had to put on IV antibiotics, possibly even hospitalize her, and those charges could run $50,000–$60,000. For this office surgery is going to be probably less than $800 total for Medicare, so it's a lot better for patients, especially patients who have high deductibles or don't have insurance. We can treat people with no insurance. In our area, 15 to 20% of people have no insurance at all, no health insurance. And so these are techniques we have to know in our area, because we would have a lot of patients, including diabetic patients, who would never get these type of treatments unless we could do it in the office under local anesthetic. They would just go on to have ulcers that get worse and lose digits or lose even their foot. So very important, not only for knowing how to correct the ulcers, but the economic aspect of it for people is got to be considered, because if you got 1/4 of your population that does not have insurance or are uninsured, they're out there walking around with ulcers and they can't get them fixed, and they're losing their feet because they can't afford to go to the hospital, which could cost $10,000 to $20,000 even for outpatient surgery. Here, this is under $1,000, and patients can afford this, or so it's just a very good technique to know, not only because it's good, but also it helps your patients in a lot of ways.